My topic is primary sinus surgery. So why this topic is uh, important? Basically, we will discuss in this topic why FES is required, how to avoid the complication, what are the pre-operative preparation, surgery, and post-operative management. So FES initially, this surgery before development of endoscope, this surgery was done under headlight and all that. Then the physiology can be compromised, anatomical structure which are normal can be damaged. So then come the FES, that is functional endoscopic sinus surgery. It preserves the physiological function and anatomical structure which are not involved in the disease. And with the advent of powered instrument and stereotactic image guided surgery, the surgery outcome of the surgery improves subsequently. So why proper assessment is required in cases of nose and paranasal sinuses? Because variable individual anatomy. There is close relationship with the orbit and anterior cranial fossa and vascular structure like sphenopalatine artery, anterior ethmoid artery, internal carotid arteries. So factors that avoid complications are thorough knowledge of anatomy, pre-operative imaging, advanced technologies such as endoscope, debrider, image guidance, good pre-operative preparation, and hypotensive anesthesia. So complications are more seen in cases when there is a revision surgery, then the pen sinus disease, when paranasal sinuses lining is descent by the disease, like in this picture, we can see lamina is very much thinned out. Then distorted anatomy, hypoplastic or extensively pneumatized sinuses, long and high cribriform plate. There here, this is a Kirus classification when the depth is more than the risk of skull base injury is more. And the presence of interethmoid artery within the nose and paranasal sinuses, or asymmetry in between the height of two sides. Like in this photograph, we can see right side skull base is much higher than the left side of the skull base. So some stable landmark which we use, especially in the case of revision surgery or even in the primary surgery, middle terminate and its remnant, posterior choana, sphenoid sinus, skull base, septum, and maxillary sinus roof. These are the stable landmarks which we use during the surgery. So in anatomy, what we primarily focus in primary sinus surgery is the osteometal complex. So in this radiology on left side, what we can see, this is the middle terminate. This one is uncinate process. This one is bulla ethmoidalis. This one is the ostium of the maxillary sinus. And this is a ethmoid infundibulum. So all these structures are known as osteometal complex. So this is a crowded space. So any infection in this, any infection in nose and paranasal sinuses, drainage of ethmoid and maxillary sinus is compromised at first stage. And so the infection is most commonly seen in the case of ethmoid and maxillary sinus. So before starting the surgery, we should know different passes like first pass, and that we can see the inferior terminate, inferior meatus, floor of the cavity, floor of the nasal cavity, septum. And if we go posteriorly, we can identify the nasopharynx, eustachian tube opening, fossa of Rosenmuller. Here is the eustachian tube opening, and this one is the fossa of Rosen. This we can see in first pass, and pathology which we can see in this in first pass is a septal perforation. We can see polyps, which we'll discuss in this. We can see adenoid and angiofibroma. This is a picture, Jonah nasopharyngeal angiofibroma. Then come the second pass, which is medial to middle terminate. So sphenoethmoid recess and sphenoid sinus superior meatus is seen in this part. So it's posterior ethmoid sinus and posterior ethmoid and sphenoid sinus drain from this part. So this is a sphenoid ostium. Any mass lesion which is occupying this area can be seen in the second pass. Like here is a case of mucormycosis with the septal erosion was present, and this is a sphenoid sinus ostium. And this is our main focus on this seminar is the third pass, which is lateral to middle terminate osteometal complex. So this is endoscopic picture. This one is uncinate process. So anteriorly uncinate process attached with the lateral nasal wall. Posteriorly it is a free border. Inferiorly it attached at the level of the inferior terminate, and superiorly it it can different attachment can be there, which we will discuss later on. This one is a third pass, and this is a case of nasal polyposis, and this is a post-op cavity, and this one is a healthy nasal cavity. So here's a again osteometal complex, see, which we discussed earlier. Uh, so in pre-operative workup, for primary sinus surgery, the surgeon how to, because risk of complication is high, to how to avoid the complication, because it has long learning curve. So surgical maneuver exceedingly limited at regular intervention should only be performed by the surgeon who has enough experience. So what literature says, up to 100 to 120 surgery should be assisted by the person before intervene as a sole surgeon. So radiology, as there is a variable anatomy, the 1 to 5 cut can be taken. If there is a gross pathology, can taken 3 to 5 cut. If there is a, if minor assessment is required, like if disease is extending till the level of skull base, and when the navigation system is used to remove the disease, then 1 cut can be taken. So we need axial, coronal, and sagittal cut. And pre-operative counseling is very important because for nasal polyposis, primary cause is the allergy, and we are dealing with a secondary cause, which is formation of nasal polyposis. So disease recurrence can be there. So patient should know what is the nature of the disease. So in topical preparation, anti-inflammatory, they have anti-inflammatory property. So it improves the symptoms. There is no significant, as we use a topical steroid, it doesn't have a significant effect on the cortisol level, growth rate, and intraocular pressure, as earlier literature shows, risk of lens opacification and local mucosal atrophy. But what literature suggests, pre-operative topical steroid therapy has not much effect on intraoperative outcome. So systemic therapy is better in such cases when surgery is planned. So RCT shows there's an improvement in olfaction, endoscopic scoring. There is a decreased polyp formation, blood eosinophilia, immunoglobulin E, and interleukin 5. And intraoperatively, it improves the surgical field, reduce the operation time, and blood loss. Systemic antifungal therapy, as till now literature shows, there is a this therapy is used primarily in the case of recalcitrated when other form of therapy is not effective or contraindicated. This one of the article is published from our institute where we use as a sole therapy itraconazole as a sole therapy to treat the nasal polyposis, and we found mixed results in this study. So other miscellaneous causes for nasal polyposis formation like vitamin D deficiency that can lead to polyposis formation and the human papilloma, but they are still in research form. So for surgery, initial aggressive surgery to clear all the sinuses for if there is a fungal mark and debris and eosinophilic mucin is present, it should be clear completely. This will reduce the risk of recurrence. Sinuses should be widely open. So in order to improve the ventilation, and it also allows a topical medication in post-op period. And to preserve the mucociliary clearance. These are the goals of surgery, and to create the wide sinonasal corridor for endoscopic examination and to provide the access to the sinus to remove the fungal mucin and application of topical medications. So in surgical position, reverse Redlenberg position is a preferred position because it reduces the overall blood level in the paranasal sinuses and upper part. So it reduces the bleeding risk. Then surgical tool, microdebrider is a good tool. It is a precise, relatively bloodless surgery can be performed as compared to the cold method. And this also helpful and prerequisite for successful outcome of this. So image guidance is required when there is extensive disease, when there is a distorted anatomy, when revision surgery is required, when the skull base and orbital party wall is eroded. What literature shows, it reduces the overall surgical time, reduces blood loss and complication rate as compared to where the extensive surgeries were done without the help of this image guidance. So in anesthesia, what we require, hypotensive anesthesia. In pre-operative preparation, if hypertension is there, it should be well controlled. Sometime administration of beta blocker and simultaneous use of these epinephrine can increase the intraoperative hypertension. So it should be well managed, and all anticoagulants and antiplatelet drugs should be avoided. It increases the risk of bleeding. and NSAIDs and some herbal medication like 4G, garlic, ginkgo biloba, and that also increases the risk of bleeding intraoperative. That should be avoided. That should not be used. And anesthesia, total intravenous anesthesia is found superior as compared to the other form of anesthesia. And if inhalational form of anesthesia is used, then zero flow provide uh, better surgical environment as compared to other form. And administration of tranexamic acid shows decrease in intraoperative bleeding, operation time, and visibility during the surgery. And topical decongestion is equally effective as compared to blocks are used, like antirythmoid block or sphenopalatine block. So it's now in current era, less number of surgeons are using these block technique to control the bleeding. So pre-operative endoscopic assessment and proper placement of graft flap is very important. Pack is very important. It helps in assessment of the nasal cavity. It improves the assessment of nasal cavity and also reduces the surgical time and reduces risk of complication. So injectable vasoconstriction, there is a different author use different form of adrenaline. Like someone use higher concentration, someone use lower concentration. So what literature says, when we are using higher concentration, there are some intraoperative changes occur, but both those changes are manageable. So it is literature is not against the use of higher concentration of epinephrine. So diagnostic endoscopy is very important. What is the disease extent? Like I showed, first pass, second pass, and third pass. Am I audible?
Yes, sir, you are audible.
Okay.
Yes, you are audible, Hitesh.
Yes. In pre-operative, these are the sites where we generally block the nerves in during surgery in a standard phase. So this is the axilla of middle terminate on right side of the left side of the nasal, right side of the nasal cavity. This is the axilla of middle terminate from where the anterhythmoid artery branches can supply this area, and anterhythmoid nerve branches are also there. If someone is doing surgery under local anesthesia, so that nerve can be blocked. And this is the region of sphenopalatine foramen, posterior most end of the inferior meatus. This is the middle terminate, this one is the inferior terminate, and this one is septum, and this one is a nasopharynx. So posterior most end of the inferior meatus, where the sphenopalatine foramen is there, and sphenopalatine vessel and nerves come inside the nasal cavity. So these blocks are required primarily for local anesthesia. These are the few other blocks like Muffets. We know Muffets is a xylocaine 4% and 1 drop of ADR is used in 6 ml of xylocaine, and that is put on the both side of the nasal cavity in Pruitt's position, with head is completely extended over the operation table, so that the tip of the nose and EAC should come in same line, and then the drops is put along the lateral wall of the nasal cavity in drop form, so it blocks the sphenopalatine artery. In this photograph, anterhythmoid this inferior orbital nerve is blocked. In this photograph, this one is anterhythmoid block, and this one is a sphenopalatine block through the greater palatine foramen. And this is the uncinate process, which I told you earlier. These are the upper attachment, and the upper attachment determines the drainage of the frontal sinus. Like in this first photograph, frontal sinus drain directly into the middle meatus when uncinate process attached with the orbit. But when it attaches with the skull base and the middle terminate, then it is drained into the ethmoid infundibulum first, then to the middle meatus. So traditional approach for uncinectomy is anterior to posterior. That was described by Mazeklinger. So in this, base of the uncinate process is identified, and either person can use sickle knife or Freer's elevator to puncture separate the uncinate process from the lateral nasal wall. But as uncinate process attached with the lateral nasal wall, it is in a close vicinity with the orbit. So risk of injury to the lamina papyracea and orbit is high when instrument is poked very much inside the nasal cavity. So tip of the instrument should always be visible during uncinectomy. Then comes the Stemberger posterior to retrograde uncinectomy. In this photograph, first this backbiting forceps is used at the level of lower end of uncinate process, then it is cut is made, and then the remaining part can be removed the debrider. If two cuts are made and it is open like a book anteriorly, if middle part is uh, pulled forward, then it is known as swing door technique. Like door, we open the surgeon opens the uncinate process, and then the deeper structure can be visible. Then comes the ethmoid infundibulum. Once the uncinate process is removed, this area is known as ethmoid infundibulum after the removal of the uncinate process, and this is a site of maxillary sinus ostium. Like in this radiological photograph, what we can see, this is the middle terminate, uncinate process after the removal of the uncinate process. This is the ethmoid infundibulum and maxillary sinus ostium. And one method is through the fontanelle, and like when there is a accessory ostium is there, so that can be used to locate the maxillary sinus. So in that case, the risk of injury to the orbit is much less if we are doing either anterior to posterior or posterior to anterior. When someone is doing retrograde form or swing door technique, then the risk of injury to the nasolacrimal duct is there because it runs in the medial wall of the maxillary sinus. Second, after the uncinectomy, then comes the maxillary enterostomy. Like in first photograph on right side of the nasal cavity, this is a maxillary sinus ostium, and type 1 is an enlargement of maxillary sinus ostium in the posterior direction, because posterior direction there's no vital structure are present, because anteriorly nasolacrimal duct is there and superiorly widening is done, then there's a risk of injury to the orbit is there. So in type 1 generally done is in the posterior direction. When this is done primarily for diagnostic, for example, if there is a minimal thickness of the maxillary sinus is present, or if you want to see what is happening inside the maxillary sinus, then type 1 is done. In type 2, and this enterostomy is open 2 centimeter posterior, larger opening is created, like in the case when there is a polyposis is seen to improve the drainage of the maxillary sinus. In this cut, in this film, what we can see, there's a fungal ball is present. So whenever there is a allergic fungal sinusitis, fungal tissue is present. In that case, type 3 is required. When there is significant exposure is required, when the person is doing want to reach in this infratemporal fossa or lateral part of the pterygomaxillary fossa. In such cases, type 3 enterostomy is done. In that case, it is open posteriorly, posterior valve till the posterior valve of the maxillary sinus, anterior till the lacrimal sac, and inferior till the inferior turbinate. Then after that maxillary wide enterostomy, next comes the anterior ethmoidectomy. So after the uncinate process removal, this is a bulla ethmoidalis. So bulla ethmoidalis is extended from the middle terminate till laterally till the orbit. Here we can see this is the middle terminate and till the orbit. So surgeon should open the bulla ethmoidalis in an entero-inferior part because it's the safest part. Like in this picture, this is the safest part. If someone is opening laterally, then risk of injury to the orbit is there. So how we can do? We can sometimes there is a space behind between the ground lamina. Ground lamina is a lateral attachment of the metatarsus to the lamina papyracea. So when there is a space between bulla ethmoidalis and a ground lamina, which is known as lateral recess, so instrument can be inserted in that space, and bulla ethmoidalis can be fractured anteriorly, or puncture can be done in the anteroinferior part, and then the debrider can be used to remove the polyp or after the bone removal. And then the position of lamina papyracea is very much important while doing the ethmoidectomy. Like there may be natural dehiscence of the lamina papyracea can be there. If disease, like in this photograph, what we can see, surgical corridor is narrow as the orbit is much medial, like imaginary line is passed through the medial wall of the maxillary sinus, and the orbit is medial to that line, then the surgical corridor is very less. In this photograph, what we can see, it is lateral to that line. Orbit is lateral to that line, then the surgical corridor is wide enough. So in that case, instrumentation is relatively easy and risk of orbital injury is less. Then comes the posterior ethmoid. So limit for anterior ethmoidectomy is laterally till the orbit, superior till the skull base, and inferior boundary which we can see, and posteriorly we can see ground lamella. So like in this photograph, this is a ground lamella after the removal of the bulla ethmoidalis. And this ground lamella is basically lateral continuity of the middle turbinate to the lamina papyracea. So this is after the puncture of this ground lamella. This is a post-ethmoid cell. Like in this radiological photograph, what we can see, this is a ground lamella. This is a middle terminate and attaches laterally to the lamina papyracea. The cell posterior to ethmoid cell, which is present posterior to the ground lamella, is known as post-ethmoid cell. And then comes the onod cell. Onod cell is a posterior extension of the post-ethmoid cell over the sphenoid sinus. So in sphenoid, what generally there is a septa, intersphenoid septa is vertical. If you identified horizontal septa within the sphenoid sinus, then it is you must have onod cell in that case. So why onod cell is important? Because optic nerve run in the lateral relationship of the onod cell. Like in this radiological photograph, this is a onod cell. It is extending superiorly over the sphenoid sinus, and optic nerve comes in lateral relationship to it. So if someone is thinking this is a sphenoid sinus and person is approaching laterally, in that case, risk of injury to the optic nerve is there if optic nerve is dehiscent or prolapsing within the sinus. So optic nerve is divided into 4 types on the basis of relationship with the ONODs, relationship with the sphenoid sinus. When there is a no indentation type 1, with there some indentation type 2, when there is significant prolapse within the sphenoid sinus type 3, when it is present with the ONOD cell, that is known as type 4. Then comes a sphenoid sinus. So sphenoid sinus is a midline sinus, close to midline. So in this axial photograph, this is a nasal cavity. So if person is approaching through the second pass into the nasal cavity, then person can identify the sphenoid sinus here, sphenoid sinus ostium here. How we can, there are 3 different approaches for sphenoid sinus, either medial to superior turbinate or either lateral to superior turbinate, or third one is intermediate approach where the superior turbinate is removed. So if someone is doing diagnostic, like in this radiology, what we can see some amount of secretion within the sphenoid sinus. In such cases, maybe diagnostic endoscopy is required and minimal widening of the sphenoid sinus is required. So surgeon can choose medial approach. But like in this radiology, there is extensive disease is present within the sphenoid sinus. There is expansion of the sphenoid sinus. In that case, lateral route is required. Lateral route is after uncinectomy, enterethmoidectomy, posterethmoidectomy, then removal of the anterior wall of the sphenoid sinus. So how we can identify the sphenoid sinus ostium? So one method is from anterior nasal spine. Ostium is 7 centimeter behind it and 30-degree angle. So what this is a relatively cumbersome method, and what we are using, it is 1.5 centimeter above the corner. So this is the left side of the nasal cavity. This is a coina. This one is the middle turbinate, and this is a superior turbinate. And here we can identify the sphenoid sinus ostium. So it's a 1.5 centimeter, 1 to 1.5 centimeter above the coina, and it is 5 mm lateral to the septum, and it is at the almost at the half vertical height of the superior turbinate. So these are the landmark, and coina is a consistent landmark for the identification of sphenoid sinus. So last sinus is the frontal sinus. So here is this is the endoscopy. After the removal of the disease, we can see the glare. So if you can identify the glare over the frontal bone, then you are basically within the, you are looking at the frontal sinus. So this in this photograph, after the removal of the anterior ethmoid cell, frontal, we can see the ostium of the frontal sinus. In a one technique where the intact bull, what we call it intact bulla technique, when there's a disease is only in the frontal sinus, bulla is completely normal. In that case, bulla ethmoidalis can be preserved and directly surgeon can reach up to the frontal sinus. So in this draft proposed 3 different kind of surgery. When there is a minimal secretions are present, in that case, when anterior ethmoid cell is removed, in that case, automatic drainage can happen. So this is a type 1. Then type 2 is further divided into 2A and 2B. In 2A, frontal sinus ostium is widened till the level of the middle turbinate, laterally till the orbit and medially till the middle turbinate. In 2B, it is up to the septum. And this is a photograph of type 3, where interfrontal septum, basically septum, nasal septum is removed, and frontal sinus ostium is widened from one side of the lamina papyracea to the other side of the lamina papyracea. This one is a crista galli, and this entire is a frontal sinus. So this is also known as Lothrop procedure. So if person is doing by open approach, then it is known as Lothrop, and someone is doing endoscopically, then it is known as modified Lothrop. Then comes the anterior ethmoid artery. Normally, anterior in 90% of the cases, an anterior ethmoid artery runs within the cranial cavity, like in this photograph. But in this is a Kennedy nipple, and it is running inside the nasal cavity. When we can identify the anterior ethmoid artery within the nasal cavity, one is if there is a supraorbital ethmoid cell is present, like in this photograph. Supraorbital ethmoid cell is present. This one is supraorbital. Then, if anterior to posterior diameter from anterior wall of frontal sinus to the skull base is more than 1 centimeter, in that case, it can run under it. If Kiros is high, like Kiros type 3 is there, then then the anterior ethmoid artery can run within the nasal cavity. When the length of the cribriform plate is long in that case. So this is a surgical photograph. This one is an anterior ethmoid artery. This is a frontal sinus. So it runs along the posterior wall of the frontal sinus. Just one to if ethmoid is there, so it's a from the anterior. If bulla ethmoidal is completely intact, disease free, so it may be 1 to 2 mm behind the anterior lip of the bulla ethmoidalis. And it is running posterior to the just posterior to the posterior wall of the sphincter. This one is a posterior ethmoid artery. It is majority of the cases it is running intracranially. So the risk of anterior ethmoid artery is very less if surgeon knows where it is running, and if someone is dealing in that part, it should be done under vision. And if you know there is it's prolapsing within the nasal cavity, so in that case central part should be handled, because if it bleeds, in that case some part may be left on both sides. In that case, cautery can be done. So these are the list of complications that can happen with the endoscopic sinus surgery. For example, nasal complications are more common. Synechia, septal hematoma formation. There may be enterostomy closure. There may be nasal bleeding. And the mucocele palsyle are the delayed complications. There may be orbital injury that can lead to emphysema, fat prolapse. If muscle is injured, in that case diplopia, injury to nasolacrimal duct. If optic nerve is damaged, then vision loss, orbital hematoma, and orbital compartment syndrome, where for example, anterior ethmoid artery prolapse within the orbit, then it can increase the pressure within the orbit, then can lead to compartment syndrome. And intracranial is predominantly the CSF rhinorrhea. Then, if skull base is damaged, and in that case, encephalocele can occur. And there may be major vessel injury like carotid can be injured, which is very rare complication, but it can be injured. Risk of meningitis if duras are exposed within the nasal cavity. There may be cavernous sinus thrombosis. Last is intracranial abscess. So packing should be done under vision. In Because in the last stage of surgery, majority of person are doing packing without examining the nasal cavity. In that case, middle turbinate can be damaged by putting the marrow cells, and in that case, synechia can happen in future. So what literature says, nasopore is a absorbable marrow cell, may be superior to the marrow cell as a nasal packing material, as it because it is soft in consistency, so pain, overall bleeding is less as compared to the marrow cell, and marrow cell is much better than the conventional, because in conventional packing technique, there is a person can injure the lining mucosa of the nasal cavity while doing the packing. In that case, the risk of synechia is high. So prevalence of synechia in absorbable group range from 4.6 to 8, while in non-absorbable group it's 8 to 37, 35.7, which include both conventional and commercial packing. So in follow-up, uh, surgeon should remove all the devitalized tissue, retained secretion, bone chips, or if there is a loose hanging mucosa, that all should be removed, because that can lead to the synechia formation. So endoscopic assessment should be done regularly in the cavity. Surgeon follow-up can be vary from 1 week to 2 weeks depending on the presentation of the patient. If patient is doing managing well, in that case, interval can be increased. And early treatment for ongoing inflammation or infection that can avoid the risk of revision surgery. So this is a post-op cavity, like this is a sphenoid sinus. This one is a choana. Here is a pituitary fossa. This is a nasal this is the after ethmoidectomy. Post-operative management is variable. Steroid have what literature shows is a variable outcome, but most of the study shows positive outcome. So one study shows a follow-up for a 2-year recurrence rate was reduced as compared to the non-steroidal group. Saline irrigation, the evidence suggests that there is no benefit of low volume versus high volume or even hypertonic saline versus normal saline. So, but it can provide some psychological benefit, or it can, when we combining the saline irrigation with the other medical management, it can reduce the, it can remove the thick secretion, even the crust. So patient may feel much better and snort score may be much better. So it's at present saline irrigation is not, it's a part of treatment, but it is not proven. Then this another method where we steroid is used as a nebulization rather than giving systematic. In that case, literature is in the preliminary stage and it is showing better outcome and reducing the risk of recurrences. And smoking should be avoided because smoking can increases the scar formation and poor healing, and that can lead to the failure of the surgery. An antibiotic preoperatively is not indicated unless it is nasal cavity is infected, and postoperatively, if one shot of intraoperative antibiotic is sufficient. When there is an active infection, if you identify there is a pus inside the nasal cavity, then can be given. If nasal packing is used for more than 24 hours, that in that case, if there is a hematoma is present, the patient is immunocompromised. Topical antibiotic has no role. So in summary, surgeon should know the anatomy very well and should assist enough number of cases before venturing into the surgery. And counseling is very much important, especially in the cases of nasal polyposis, because the cause is allergy and we are dealing with a secondary problem, that is polyposis. We are not removing the allergy, and then the risk of recurrence is there. So patient should be well aware about the follow-up. So intraoperatively position is reverse Rettenberg is a preferred position in anesthesia. TY is preferred if TY is not available. In that case, euflorin can be used. Steroid has systemic steroid has better outcome as compared to patient who are not given. So pre-operative and post-operative have both good result, but it associated with long list of side effects. So should be used cautiously. Antifungal still not in antifungal is given in few literature, especially from the India, and they showed promising result. But it is as antifungal treatment is required for prolonged period. It may be minimum 3 months or 6 months. So cost may be the concern for the patient. And pre-operative use of decongestion like nasal packing during the surgery and infiltration like various blocks can improve the surgical outcome. Antibiotic single shot intraoperative is sufficient, and post-operative irrigation of the nasal cavity is very important part of the surgery. Thank you. Hello.
Yes, sir. You are audible, sir.
Yes.
Yeah, thank you, Dr. Hitesh.
Thank.
That was a very good talk, highlighting all the basic aspects of primary sinus surgery, starting from the preoperative preparation of the medical preparation of the patient, and then the main things which we have to remember while doing the surgery. So excellent talk. Do we have any questions in the chat box? Are you able to see Any questions, Hitesh? Participants, you can, we have 10, 12 minutes if there are any questions. So I think
So from
yeah,
Dr. Vaibhav is asked first pass, second pass, and third pass.
yeah.
So first pass is along the floor of the nasal cavity. So what we can see in first pass, inferior turbinate, inferior meatus. Wait a minute.
Yeah, maybe you can show the slides.
So this is a first pass. If a person is doing endoscopy along the floor of the nasal cavity, this is inferior turbinate, inferior meatus, and this one is a septum. If person is going posteriorly, then nasopharynx is there. So this is a first pass. Then comes the second. These are the pathology which can be seen in first pass, like septal perforation, nasal polyps if it is extending till the nasal cavity floor, adenoid, and this is a case of angiofibroma. Then comes the second pass. Second pass is medial to middle turbinate. So like uh, in this photograph, what we can see, if person is going medial to the middle turbinate, in that case, part of septum, cribriform plate, and sphenoid sinus ostium, superior turbinate, these are structures which are visible in the second pass.
And also maybe one can comment upon the olfactory cleft.
Yes, ma'am. And in third pass, it's lateral to middle turbinate. So what we can see, this one is a uncinate process, like this is the uncinate process. And these are the nasal polyps within the middle meatus. And this is a post-op cavity. So better picture this. Like here you can see this one is uncinate process, this one is a bulla ethmoidalis, and this one is a middle turbinate. So these structures are seen in the lateral part.
So it is important to understand these three passes because this is a standard terminology that we use. So, so reporting any abnormalities in any of these passes, that's a standard procedure now. So everyone should kind of report any pathologies in these passes only: first pass, second pass, and third pass.
Sphenoid ostium identification. So sphenoid ostium, so in this slide, what we can see, uh, what surgeon predominantly use to identify the sphenoid sinus ostium is a choana. So choana is a consistent landmark, and 1 to 1.5 centimeter above the choana, you can identify the sphenoid sinus ostium. It is 5 mm lateral to the septum, and it is at half to two-third distance of superior turbinate, vertical height of the superior turbinate. And this is another method where anterior nasal probe is passed from the anterior nasal spine at the level 30 degree. Then at 7 centimeter distance, you can identify the sphenoid sinus ostium. So role of navigation is FES. I told you if there is extensive disease, when there's a significant anatomical distortion, like for example, skull base is eroded, orbital medial wall is eroded in that case, or if you are dealing primarily with the cancerous cases where the margin requirement is very much important, in that case navigation can be used. If disease is limited, in that case it's not required because vital structures are present. By navigation we can identify vital structures are more when this anatomy is abnormal, because it's provide us the site where we are dealing. That is done with the help of navigation. So anatomical variation is primarily related with the drainage of the basically frontal sinus. So superior attachment is important. So if for example if someone is dealing with the frontal sinus pathology and superior attachment is not handled carefully, in that case maybe after surgery drainage may not be improved because superior part should be removed in that case. And one entity I have not told you for frontal sinus, one is axillary flap approach. And that what is done at the level of the axilla of the middle terminate, flap is created, posterior base flap is created, and that flap uh, allows exposure of the frontal beak. And frontal beak is a bone which is present inferior to the frontal sinus. And if person is removing that frontal beak, then directly through that window, surgeon can see frontal sinus with a 0-degree endoscope. So how to decide? So polyp should be removed completely because polyp, because it can, if partially is removed, in that case maybe nasal cavity is improved, but disease recurrence can be there. So polyp should be removed completely. Uncinate process attachment anteriorly, like in this photograph. So in this photograph, what we can see, uncinate process on the right side, it attaches laterally with the lateral nasal wall. Posteriorly is a free edge, and space between free edge and bulla ethmoidalis is a hiatus semilunaris. As inferiorly it attaches at the level of the inferior terminate. Here this is the inferior terminate attached with the inferior terminate. Superiorly there is a variable attachment. One is with the lamina papracia, other one is a skull base, and third one is with the middle terminate. Yeah, systemic steroid have role. As such, steroid can be used for 2 to 3 weeks. It literature shows good outcome with the steroid, but it is associated with the list of complication, and few people are you may find contraindication like uncontrolled diabetes or some systemic illnesses like hypertension is there. If patient is having vision issue like initial stage of cataract, in such cases you may avoid. But now currently literature is focusing more on steroid irrigation, so that maybe in future may show equal outcome. So anterior to posterior approach is basically used at the first time of surgery. Second time of surgery, that can be also used if anatomical landmarks are there. If anatomical landmarks are not available, in that case posterior to anterior approach is used. In that case choana is first identified, then goes to sphenoid sinus, then surgeon can identify the skull base and follows anteriorly. So for example, middle meatus enteroscopy, in that case, if for example in radiology you just find some amount of secretion, minimal thickness, in that case you may require just a diagnostic scopy after the ethmoidectomy. So in that case minimal widening of the ostium can be done, that is type 1. If there is a polyposis, polyp formation occur within the sinus, in that case type 2. Or if you are dealing with the allergic fungal sinusitis or with the tumor like inverted papilloma, or if you want to access later into the infratemporal fossa, in that case type 3, which is almost complete removal of the medial wall of the maxillary sinus.
Hitesh, there are no more questions, I think.
Yes, ma'am. This was the last question.
Thank you, sir. Thank you, ma'am. Thank you all trainee for joining this session.
Yeah.
Okay, thank you.
So, Dr. Hitesh, once again for the